keynote of the day, Dr. David Galbis-Reig. Dr. Galbis-Reig received his doctorate degree from Virginia Commonwealth University, Richmond, and his residency in internal medicine at Aurora Sinai Medical Center. Currently, he's the Director of Medical Services for the Inpatient Mental Health and Addictions Unit at Wheaton Franciscan All Saints, where he passionately advocates for appropriate medical treatment of patients with mental health and addictive diseases, as well as provides education activities to decrease prescription drug use. He is an active member of the Wisconsin Medical Society and a member of the Board of Directors of the Wisconsin Medical Society Foundation. Please join me in a round of applause and for a warm welcome for Dr. Galbis-Reig.
Thanks a lot. Thank you very much. Happy to be here. Let me get started here. I do have some disclosures. I have an IRA and I kind of played around with it, so I've got a couple bonds. I have bonds and Pfizer and some. None of this, by the way, is financially relevant to what I'm doing, but I have to report it. It's Cortex Pharmaceuticals, GW Pharmaceuticals. My wife worked for Abbott, so we've got stock in all the Abbott subsidiaries. So the objectives today, essentially, we want to discuss the prevalence. I want you guys to be aware of the prevalence and the societal impact of the prescription drug abuse problem that we have right now. But in relation to that, we're going to talk about how that gets us to heroin. Understand risk factors for progression from prescribed opiates to heroin, and describe the epidemiological data demonstrating a link between prescribed opiates and the amount of prescribed opiates, and then getting to the point where it's increasing heroin addiction or heroin use. And then be able to describe how society can begin to decrease the risk. So how do we go from where we are now to get that risk down over time? And it's not going to be a fast process. So I've got several case presentations. This is the first of them. And these are real patients. They're patients that have been admitted to the unit over the years, some more recent than others. This is a 25-year-old Caucasian male. He presented to our unit with a 3-year history of intravenous heroin addiction for detox and referral to treatment. He denies any history of marijuana use, tobacco dependence, cocaine use, or other illicit or prescription drug use. The reason that's important is that's a huge change from the 1980s. In the 1980s, when we had people that would come in with heroin addiction, a lot of times it was a progression from marijuana, tobacco, through some of the other substances, all the way down into heroin. It didn't start without any of these other drugs ever being used, and this guy had never used anything else. In fact, he really thought these were crappy drugs. Patient reports being prescribed opiates. He was prescribed Vicodin for the first time when he was 16 years old for a fracture. He had a really bad tib fracture, which if anyone's ever had, it's a huge bone. It's a really bad fracture. It usually requires surgery, which it did for him. And he was put on the Vicodin, and what happened is after a certain amount of time, the docs decided, you don't need these anymore, which you shouldn't, and they stopped prescribing them. So he started having cravings. He said he never had withdrawals when they were stopped, so he didn't have the classic, the shakes, the diaphoresis, all the typical stuff they would see with opiate withdrawal, but he said he really craved the drug, and he couldn't resist the craving. So he initially started finding pills from friends, and he would borrow, quote unquote, borrow some from his mother. He was basically stealing from his mom, who had cancer at the time. When the supply ran out from his friends, he started purchasing oxy off the street. And during this whole time, he just, he didn't really, he told me he knew he wasn't treating pain, but he couldn't understand why he still needed it. He reports theft. He started stealing to make money because he kind of lost everything to maintain his habit. At the age of 18, his parents sent him to quote-unquote rehab out of state. They had one of those really nice ones, kind of one of those resorts. They had some money. When he returned to Wisconsin, he stayed sober for about a week before his contacts, a lot of these people call them connects, before his connects caught up with him and he started taking them again. He moved in with a girlfriend that he met at some point along the way and moved out of his parents' house. because he was tired of his parents, quote unquote, controlling him. They were trying to get him help, but to him it was them controlling him. He started working, but he couldn't keep a steady job, primarily because he was pretty inconsistent with attendance. So he ended up being admitted several times for detox, and he had at least one accidental overdose 5 years prior to admission. At the age of 22, his supply of oxycodone was running dry, and it was getting too expensive too. By that point, and this was fairly recently, I mean it was within the past couple of years, by that point the supply of oxy had changed. OxyContin was now that non-abusable form, which we'll talk about, or the abuse-deterrent form, and the Percocets and oxys were getting more expensive because the supply was actually starting to dwindle a little bit. So one of his suppliers introduced him to heroin. And most people that deal usually have some heroin with them because they know that the supply of prescription drugs is not consistent. And so at the age of 22, he started snorting heroin. He never thought he would inject. Within a couple of months, he had started injecting heroin because someone told him that it was a better feeling. And by the time he came into the hospital, he had been injecting over 1 gram of heroin a day. He denied use of any other prescription drugs at that point, illicit substances, tobacco products, or alcohol. This guy never smoked cigarettes, had never used marijuana, which is in the old days that would be unheard of, but had progressed from getting a prescription for Vicodin down this path. His last use of heroin was approximately 13 hours prior to admission. Really didn't have any other medical issues. He actually denied pain. He said he really hasn't had pain since the surgery. He said, the docs were right, I didn't have pain, but I couldn't get off. I just felt like I needed it. He's no prescribed meds, no allergies, really nothing to hear of. I mean, he's still living with that girlfriend who now is also addicted to opiates. She was not when she met him, but is now also an opiate addict, and she actually ended up going into treatment as well, but not with us. She ended up with another facility. Sometimes we try not to take the people that have a close relationship. We have at times, and there's no other options, but unemployed and not on disability. He did complete high school, but no college classes. It's amazing this guy completed high school as much as he was using it by the time he was a senior, but mother and father are healthy. They have no history of addiction in his family as far as he's aware, and no mental health issues. Two of his sisters are healthy. They actually don't talk to him anymore because they think that he's a loser. That's what he told me. He said that's what they told him. He has no children, no other family history of any other problems. His physical exam was pretty common, depression, anxiety. He had disappointment by the time we saw him, track marks, both upper extremities. He had a heart rate of 108, so he was kind of in withdrawal. Fortunately, he had no cardiac murmur. The reason that's important is people that are injecting, they can get an infection of the heart valves, they can get endocarditis. You want to make sure they don't have that. One of the cardinal signs is a heart murmur, also fever. He had clear lung fever. He wasn't suicidal, and he's never had any other symptoms of mental health issues. He has had elevated liver enzymes, and sure enough, he has hepatitis C, which is not unusual. Hepatitis C is actually a marker for injection drug use if you see it. That person most likely, although not 100%, but most likely has used injection drugs at some point, because we don't, nowadays, especially in young people, the transfusions don't tend to cause hepatitis C. We test pretty regularly. So, we've gotten to a place where, in the 1990s especially, people started to really rev up the amount of prescriptions that were available, and there was a lot of forces involved in that. It wasn't like physicians one day just said, okay, we're just going to start writing scripts for Percocet and oxycodone and Vicodin because, it's fun. Physicians didn't think that way. I mean, what happened is there was a lot of pressure on physicians to prescribe, primarily for chronic non-cancer pain, and the restrictions on prescribing changed. And we got into this culture where basically people like to take a pill for what ails them. So what we saw in the 90s, especially by the mid-90s, this really revved up. And if you look at graphs that show the amount of opiate prescribing that happened prior to about 1995, it's pretty steady. And then about 1995, it started increasing. In 1998, it really skyrocketed. So you saw a rise in prescription sales. And that inexorably is going to lead to some prescription drug use and abuse. The more out there, the more we know it's going to get abused. And of course, that's going to lead to down the path to either progression to heroin or increased opiate drug-associated mortality and morbidity. And there's really good articles in the Journal of the American Medical Association regarding this relationship and how we've gotten to this point where we're now seeing an increase in heroin use, which has really escalated since 2011 when the OxyContin formulation was changed, and we'll talk about that. So in 2011, some of you have seen these before, and I'm sorry, but in 2011, hydrocodone prescriptions topped all others. So hydrocodone was the most prescribed drug in 2011, and for many years thereafter, before that and after that, even above medications for diabetes, heart disease, high blood pressure, high cholesterol. It was the most prescribed drug. Prescriptions for all opiates exceeded 238 million in 2011. And the interesting thing, these are really amazing statistics. So in 1997, there was 96 milligram morphine equivalent. So when we think of opiates, we think of them in terms of the equivalency to morphine, because morphine is the quintessential opiate. It's what we get out of opium. And so we compare everything to the potency of morphine, which is a fairly low potency opiate. And in 1997, we were selling about 96 milligram morphine equivalents nationwide. By 2010, that had gone up to 710 milligrams morphine equivalent. So that's the large increase. And now there's enough opiate in the United States to basically supply every adult American with 5 milligrams of hydrocodone every 6 hours for 45 days. That's what's floating around. And you can see these trends. And it's not just, we've seen this trend not just with opiates. Stimulants, this is stimulants, okay? It's hard to see, but this is prescriptions for stimulants. Stimulants have also increased, pretty much linearly, almost like opiates have. This is also a really amazing statistic. So the United States consumes 99% of the world's supply of hydrocodone, 99%, and 83% of the world's supply of oxycodone every year. I don't know what that says about, our pain in this country. Gram for gram, people in the United States consume more opiate medication, so it's not just hydrocodone, oxycodone. They do use different opiates in other countries, but we still are higher in everything. We consume more opiate medications than any other nation in the world.
Is this like legal prescriptions?
Yeah. This is not heroin. These are prescribed opiates. Hydrocodone with acetaminophen, which is Vicodin, was the #1 prescribed drug. We talked about 2011, but it's actually the #1 prescribed drug for the years that we have data so far. We have data now for 2012, and it was still the most commonly prescribed drug for 2006 to 2011, but actually now even into 2012. My colleagues in medicine say, well, that's good. We're treating pain. We're finally treating pain. Maybe, maybe not. We have to stop and think, what are we doing? When you increase the supply, what are the side effects? What about the risk? What's the downside? And what is the evidence that we're actually treating pain? So as far as the problem, so what has this done? So in 2009, 7 million Americans reported non-medical drug use. Non-medical means that you're using a pill for something other than its intended use. And that could be taking someone's Vicodin because you have back pain, which is a use for Vicodin, but it's not prescribed to you. So taking someone else's Vicodin when it's not prescribed to you is using a medication other than intended use. The most widely abused medication class, by the way, is not a controlled substance. They're antibiotics. How many times do people get an antibiotic for pneumonia or something else to put in their medicine cabinet because they're feeling better, so they don't go through, doctor says take it for 10 days, you take it for 5 because you're feeling better, so you leave the rest of the 5 for a rainy day just in case you get sick, you don't have to go back to the doctor. Well, that's abuse. You're abusing your antibiotic, you're not taking it like the doctor intended. And so the antibiotics are actually highly abused drugs, but they're not addictive. So when you look at the drugs that people are using, the prescription drugs, that's more than you see with cocaine, heroin, hallucinogens, and inhalants combined. So you combine all of these, and you're seeing more people using non-medical drug use than these. And these, when we talk about current non-medical drug use, we're talking about controlled substances, not antibiotics. If we had antibiotics, it's ridiculously high. Abuse of prescription drugs now ranks second only to marijuana. Marijuana still takes the lead as far as drug use. 2.2 million Americans use pain relievers. So of the 7 million, 2.2 use pain relievers non-medically for the first time in 2009. So when you take this graph, and the colors are hard to see, but so on the left here, this is marijuana, okay? So percentage-wise, prevalence of past year drug use among 12th graders, these are seniors in high school. About 35% reported use of marijuana. Now, that doesn't mean daily use. If they used once, they basically were asked if they ever used it in the past year. So this could be someone that used it once, it could be something they're using on a regular basis. But 35% of seniors in high school reported use of marijuana. Now, when you add, look at the second drug, by the way, Vicodin, 8%. But when you add Vicodin and Adderall, which is a prescribed drug, and tranquilizers, which are prescribed drugs, and OxyContin, which is a prescribed drug, and sedatives, which are prescribed drugs. When you add, and Ritalin, by the way, down here, which is a prescribed drug, when you add all of those, if you put them all together in one column, it's just below marijuana, not by much. But you see two opiates up here, Vicodin and OxyContin, which are fairly regularly abused by seniors in high school. 8% and 5.1% of seniors reported using it. Notice what's not on here, heroin. Heroin's not up there. Correct, yeah. So when you look at millions of Americans using it, so this basically demonstrates that by class of drugs, so you take the stimulants, 1.1 million Americans report stimulant abuse, sedative and tranquilizer, 2.6. Sedatives include things like Xanax, Valium, some of the sleep aids like temazepam or Restoril, even the less addictive ones of Ambien and Lunesta, they're all lumped into that category. Pain relievers are opiates, and that by far is the highest class of prescribed drugs that's abused. Admissions, and again, we're still on prescription drugs, and the reason I'm focusing on that right now is I want you to understand where this all came from. So prescription opiates, other than heroin, so this does not include heroin, so admissions for treatment of opiates other than heroin rose 450% between 98 and 2008. So in 10 years, we had a 450% increase in admissions for other opiate drug dependents. Number of fatal poisonings involving prescription opiates, and again, we're just talking about prescription opiates. And the important thing to keep in mind is when people overdose, the majority of people are not overdosing on just one drug, unfortunately. They're using numerous drugs. The majority of what we see is polysubstance overdoses. It's with alcohol, whether it's with benzos. Soma is a very common one too, because many people assume that it's not addictive or a problem, and soma is a barbiturate. It suppresses respiration. So it's usually a combination of drugs, but of the ones that are documented with opiates, it tripled between 99 and 2006. So the number of fatal poisonings involving opiates tripled. Drug Abuse Network, DAWN, Warning Network, this is it monitors emergency department visits in selected areas across the country. There's a certain number of emergency departments that participate, and what they found is that 305,000 emergency department visits involved non-medical use of prescription pain relievers. So what we've seen because of this is this trend. So on the left was 1999. So the biggest cause of death in 1999, excuse me, was injury by firearms. And that, it could be suicides, it could be, although suicides are classified separately, so I'm assuming that this was just either homicides or accidental shooting. Suicides were in here, as were motor vehicle accidents. But you see this line right here, it was pretty low. It was less than 20,000 in 1999. That line now has increased to almost 40,000 deaths, and this is drug-induced deaths. And drug-induced deaths are overdose from any drug. Okay, so this is not just prescription opiates, this is any drug now. But you see that trend has been very linear, while the other ones have been very flat. So we have a problem. This line is getting bigger, nothing else is. That means something's not right here. Drug poisoning in the United States in 2008 contributed to fatality every 15 minutes. So every 15 minutes during this presentation, approximately 6 people are going to die or be poisoned. Opiate medications are shown to contribute to 1 death every 30, so I guess every 30, of those 15, every 36 minutes someone dies in 2008. Opiate analgesics are responsible for more deaths than the number from suicide and motor vehicle accidents combined. That's staggering. That used to be what killed most young people, and now it's opiate overdoses. Opiate analgesics are responsible for more deaths than cocaine and heroin combined. So when I talk to pain management I think pain management really is aware. Primary care is a bigger challenge. A significant relationship exists between how much opiate is out there and available and what is going to be the side effects. So the more opiate, the more the side effects. It's a dose-dependent effect. So, and it's a societal dose-dependent effect. And what I mean by that is if we flood the market with opiates, more people are taking them and more people are likely to die. So go to case number 2. 24-year-old female presents to an inpatient mental health unit, and again, it's another young gal, 24, for treatment of heroin addiction. So you get the history on her. She started experimenting. This one did start experimenting with cannabis once or twice at the age of 13 and 14. She said, some friends were using it, and she tried it. She really never liked how it felt. She really never tried cigarettes because she had read and heard all the stuff that it was going to kill. So the good news about all this is we know education works. A lot of these kids don't smoke. They don't smoke because they know they're going to die. So, I mean, but what I hear all the time is, well, yeah, cigarettes will kill you, but these are prescribed drugs. They're happy to safe. They're tested. They're approved by the FDA. They're pretty safe. At the age of 15, she was a restrained passenger in a motor vehicle accident. A friend was driving, an older friend, and she suffered multiple traumatic injuries. She actually had her seatbelt on, and I give her credit for that, but she was a really bad accident. She did survive, but had multiple fractures. 2 ribs were broken, and she had a compound fracture of her humerus, and she ended up requiring 2 surgeries to correct that. She was started on Percocet by the surgeon postoperatively, which, by the way, is appropriate. Obviously, she had a fracture and she had surgery. She's in pain. That's not inappropriate. Her pain was not, although I probably would have used something different, but that's fine. Her pain was not well controlled after 4 weeks, and she was eventually sent to pain management because the surgeon was concerned. There was some question about whether or not she was using these too quickly, but surgeons don't routinely get an addiction history. I don't know if you've noticed that. There was some concern. So he did the right thing. He sent the surgeon sent the gal to pain, and it was a guy, I knew the surgeon, but sent her to pain management. The patient denied initially feeling high, and she said that she just wanted pain relief. After taking the opiates for a few years, she started to notice she was running out of the prescriptions early. So she's one that really felt she was taking it for the right reason. She was taking it for pain control. But after a few years, she started running out early. She did well in pain management for a few years. I mean, she was a model patient. She would come in every month. She would get her prescription. She would take it as directed. She would never run out early. But a couple of years down the road, she was starting to get in trouble. By the age of 21, she had been terminated at that point by 3 pain management providers. And was having to, quote unquote, get her pain medications from friends, family, and quote unquote dealers. She tried to obtain them legitimately through primary care providers. She went to urgent care. She went to the ER because she didn't want to be labeled as someone that was abusing her medications, even though she knew at that point she was. She was eventually unable to find oxys, which her drug of choice was, on the street, and the Vicodin just did not cut it. I mean, Vicodin for her she said it was like candy. It did nothing for her. One of her friends, and she was using, by the way, oxy. When she was on the oxy, she was using 360 milligrams a day. One of her friends introduced her to heroin. I put friends in quotations because we all know that's not really a friend. For her, it was at that time. She first snorted heroin, and notice another trend. most people don't just go straight to injection nowadays. And there's a lot of reason for that. The heroin's a lot purer, so you can actually snort it, but eventually most people end up injecting. She snorted it for about 7 months prior to admission, and then started injecting in her arms 2 months prior to admission. And again, someone had taught her how to do that and had showed her. She comes into the hospital because her family, amazingly enough, her family had no clue any of this was going on. Her family finally discovered that she was using heroin, and they found, I can't remember all the details, but I believe they found her passed out at one point with a needle in her arm still. And she was able to be revived, and she did fine, but she refused to stay in the hospital, and it just kind of escalated from there. So they essentially told her that she either gets help or they're no longer going to support her, so she was afraid of losing that. And prior to admission, her last use was 9 hours. Most of that was spent in the ER, unfortunately. Again, this woman has a significant chronic pain syndrome. The question becomes, how much of it is her chronic pain due to the injury that she had at this point 9 years ago, and how much of the pain is now produced by the opiates themselves? Opiates long-term actually create chronic pain, and that's part of the problem with these drugs long-term, is that as you take them, after about 16 weeks, when people are prescribed these for chronic pain, the pain actually gets worse. It's much harder to treat. They become more highly pain sensitive. And that was part of what happened to this young girl. And at the end, I'll tell you, she actually is one of my nice success stories. She actually done really, really well. Fracture, she had that fracture, no other prescribed meds, no allergies. Actually, she wasn't seeing anybody at that point. She still was living with her parents. She did finish high school. She started college but dropped out. She just couldn't keep up, she was missing half of the classes. And she's still unemployed. Mother had a history of anxiety. It's unclear what that meant. I never figured out. My suspicion is she actually had more than anxiety, but the daughter wasn't really clear. Father has been in recovery from alcohol for 22 years, so she had risk factors. She has a family history of addiction. And then the family always talked about the grandfather, who they were estranged from, as drinking a lot, but no one ever really called him an alcoholic. No children and no other family history. So when we look at prescription opiates, one thing we have to remember is it's a fine balance. Anytime we prescribe something, and we're having the same issue with antibiotics, and I tell people that one of the reasons that we started with something we call an opiate stewardship committee is it's not any different than antibiotics. As you've all read in the news with antibiotics, because we prescribe them for everything, bacteria are getting resistant. Anytime we do something, every action has an equal and opposite reaction. The laws of physics stand in everything. When we do something, something is going to happen. When we prescribe a lot of opiates and flood the market with opiates, bad things are probably going to happen, because unintended consequences of flooding the market with drugs that could potentially kill people is that they're going to potentially kill people. And that's what we've seen. It's an unintended consequence of trying to treat people's pains, because physicians have felt pressured to do so by a number of different outside forces, and part of it was this pain as a fifth vital sign. I have a whole talk on that thing, but I could go on for hours on that. So the question is, so we got to the prescription opiates. See, we understand how we got here. At least we understand that now the problem is there's all these opiates floating around. But how did someone go from prescribed opiate? And you got to talk about kind of an idea from the case history, but how does someone go from a prescription opiate to heroin? And there's a lot of market forces involved and a lot of interpersonal things, and we'll talk about all that, but really what happened, this is a great graph. This is, by the way, a study of, this study, by the way, was funded by the company Purdue Pharmaceuticals that got in trouble for marketing OxyContin as a low addictive potential to physicians in the 1990s, which is one of the reasons OxyContin became such a popular drug. And Purdue actually got sanctioned, I can't remember, $300 million, I don't remember, but they had a significant fine because it was false advertising. But they did this study because what they did then is they wanted to make amends, so they created an OxyContin that was abuse deterrent. So this OxyContin pill, it's the OP pill. You can, if you crush it, it turns into a gel, so you can't snort it. It doesn't dissolve in water easily, so you can't inject it. It's a thick gel. So you can't inject it, you can't snort it. It's very hard to abuse this. I'm sure at some point someone's going to figure out how to make it easy to abuse. But for now, it's not a very likable drug. And we know that because one thing is they've tracked use on the street, and one of the things you see is that this is the OxyContin here. After the formulation, its use has actually decreased in almost every measure that they've looked at. The interesting thing and the corollary to that, and the bad thing is, again, many of the people that were using this inappropriately are addicted to opiates. They're not, unless you treat the addiction, they're going to still use opiates. So many switch to heroin. So the green is heroin. You see the amount of heroin being used is very high now. As this goes down, this goes up. So people just switched their drug of choice. And you know, I've talked to a lot of patients with addiction to opiates and who currently either don't have a heroin and they swear, I'm never doing heroin, never, ever, ever. That's a horrible drug. You know, it's bad. People end up injecting, end up dying. But they're abusing 360 milligrams of oxy. And for some reason, there's a disconnect between that and the fact that heroin and they're the same drug. If you look at the chemical structure, they almost look identical. There's a few differences that make them different, but as far as the molecular structure, they're fairly similar. Opiates are opiates. They affect the brain the same way. Some are longer acting, some are shorter acting. And heroin happens to be very short acting and gets in the brain fast. But all opiates have the potential to kill. Doesn't matter whether it's codeine, it doesn't matter whether it's heroin. I mean, they all have an equal opportunity, they're equal opportunity offenders. But patients risk, the patients stratify the risk though depending on the opiate. I mean, I've talked to people, you know, codeine to them is like, yeah, that's not, I mean, you could take a lot of codeine and you're not going to die. Theoretically, that could be true. It really depends on how you metabolize the codeine, but most people don't realize that they're all opiates. It doesn't really matter. If you take enough of any opiate, you're going to die. So what are risk factors for progression? This is a great, and I mean I can somehow, I don't know how I can either offer, you know, I can give it to Deb Luber or someone about so that you can get it from. But this article, this was published in the International Journal of Drug Policy. It's a qualitative analysis. It really is not what we in medicine call a double-blind, randomized, placebo-controlled trial. What they did is they took two cities in the United States that are very different. One is Philadelphia, where they have a huge drug problem, and the other one's San Francisco, where they have a drug problem, but it's a little, you know, it's a very different environment in San Francisco. So they took two different cities whose supply of heroin comes from different places. And they looked at what was causing people that are on prescription opiates, how did people get to heroin? So what they did is they went out to places where people were using heroin and buying the heroin. So they went to the street and they found people using heroin and they asked them, what was your progression? Kind of like I did in my cases. What was your progression? How did you get to this point? And it was very fascinating because there's a lot of differences depending on the age of the person using, depending on the city, and we'll talk about that and how quickly they progress. The interesting thing is, most of the younger folks, anyone under the age of about 30, progress to heroin as in what we call an opiate initiate. They started with prescribed opiates. Most people over the age of 30, particularly the older heroin users, the 50s and 60s, progress down what we would call the traditional manner where they started with, you know, marijuana, they went to cocaine, they tried, you know, they dabbled in things until they ended up with heroin. But it's a very fascinating study. This is a great read if you really want to understand how people get, it's a qualitative thing, so it's really not quantified, but it has a lot of nice quotes from actual users and how they got to where they are. But one of the things they found when they were studying, what they did is, so they got all these interviews, then they looked at the factors. So several factors became very quickly apparent. Drug characteristics was very important. So one of the biggest important factors is the purity of heroin in the area. If you have low purity heroin, the chances that someone who's using a high purity pharmaceutical grade compound is going to switch to a low purity heroin is a lot lower, because this isn't going to provide what they want if it's low purity heroin. If it's high purity heroin, they're more likely to progress to heroin because it's going to give them the same results. Because it's a more pure compound, more similar to a pharmaceutical grade prescription drug. The other big factor, and many of them mentioned this, was the change in the oxycodone formulation. So when Purdue did change it to the abuse deterrent form, and it's not abuse, it's not abuse and I mean, you can still, I'm sure that, like I said, someone's gonna find a way, but at this point, it definitely is abuse deterrent. People don't tend to use it, abuse it as much as they used to abuse the regular OxyContin. That really did change some of these people. A couple of the users basically said that's when they switched to heroin because they couldn't find the regular oxycodone anymore, or OxyContin. Drug costs, obviously, if heroin costs more money than prescription drugs, people are going to start, use prescription drugs more often. A lot of it is just economics. What can I afford? Drug availability, how easily is it available? If heroin is very hard to find, you're not going to see people switching to heroin. If it's available on every street corner, it's more likely they're going to be exposed, and it's more likely that it's going to be normalized in their eyes and more likely to use it. And the geographic distribution. So if you have to go, if you're a middle class white guy, and you have to drive into, especially in Philadelphia, if you have to drive into their ghetto, it isn't a fun experience. The chances, the likelihood that you're going to switch is a little less if that's the only place you can get heroin. So geographic distribution makes a big impact. So, and it was very different in San Francisco and Philadelphia. And in San Francisco, the interesting thing about San Francisco when this study was done, and this study was published in 2014, so it's a pretty recent study. So in San Francisco, they have what we call black tar heroin. So it's a very impure form of heroin. It actually looks like tar, it's black. People think heroin's a white powder. Heroin comes in every color you can imagine. There is no specific heroin, but it's not very highly pure. So purity rates in San Francisco are range anywhere from like 20%. What I mean by that is it has a lot of things that are cutting agents. They put a lot of other crap in there because it increases the volume, increases the weight, and guess how the dealers sell it? They sell it by weight. So you can use less product and make more money. And even better, in San Francisco, it's extremely expensive. So you have really low purity heroin in San Francisco that's very expensive. Whereas in Philadelphia, the Colombian cartel, which used to basically specialize in cocaine in the 80s where there was a really big thing, they have now branched out into heroin. And they're using their own distribution networks. And the purity of their heroin, it's very high purity heroin. In Racine, we've seen purity of heroin as high as, I believe that the enforcement people told me as high as 95%. That is extremely pure heroin. For an inexperienced user, for someone who is used to using 40% pure heroin, if you use 95% pure heroin, you're probably going to die. I mean, that's a very high purity for most heroin. Most heroin's not that pure. But when you have high purity heroin, it makes the transition easier, especially when you're using a lot of oxy. 360 milligrams of oxy is a lot of opiate. So in Philadelphia, the other issue is that the cost of heroin, this high pure heroin, is very cheap. The Colombian cartel is able to keep it at a very low price because they deal with volume. So it's all economics. It's amazing, these businesses. I mean, but Philadelphia is a lot easier for people to transition. And the other thing is, the dealers were everywhere. They weren't localized in like a downtown central area. They were everywhere. You could find people that would deal heroin anywhere. The introduction, like I talked about, the drug deterrent, abuse deterrent oxycodone. So a couple things happened. It was introduced in 2011, and there's a lot of great articles now published that show that in 2011, there was a huge decrease in the amount of OxyContin on the street. There's a huge decrease in the likability of OxyContin because people that were abusing the old extended release OxyContin were abusing it by doing two things. They were either chewing it up, so chewing it and getting intramucosal, or three things. They were crushing it and snorting it, or they were dissolving it in a liquid and then injecting it. Interestingly, injection use is much lower on that scale. Most people were snorting it or were chewing on it. The abuse deterrent form really does not allow for that. There is no intramucosal absorption if you chew it. It turns into this little, really disgusting gel. If you crush it, it turns into a gel, so you can't snort it because it's not a powder anymore. You can't smoke it because it's not, there's something about it, I can't remember all the details, but there's something about it that just doesn't, it's not allowed, it doesn't incinerate the same way or something, I can't remember all the details, but, and you definitely can't inject it because you can't get it out of that gel form. It doesn't dissolve in water. So it made it very difficult for people that were using OxyContin to get the same effect. Because when you take it orally, if you take it like you're supposed to, it goes to the liver and you lose a lot of it. The liver metabolizes quite a bit of it, so you're not going to get the same feeling. So when that happened, the DEA actually warned, the DEA actually basically said, okay, we like this abuse deterrent form, we think this is going to be huge, but we want everyone to be aware that this reformulation is likely to cause a shift to heroin. Because they were smart enough to realize these addicts aren't going anywhere. People with addiction don't just disappear. It's not like you take the drug off the street and they just miraculously are cured. It doesn't happen that way. So if you take their drug of choice off the street, they're going to switch to something else unless they're treated. So that's what ended up happening. And the DEA did say that. They were very aware of that. They actually warned, they sent warnings out to ERs, they sent them out to a lot of healthcare providers. So they were very aware that their decision would cause a shift, which it did. The low purity black tar, as I said in San Francisco, the interesting thing about the qualitative study is that they described that there were people that, what happens in San Francisco is most people don't initiate use in San Francisco. In Philadelphia, most of the people that they interviewed were born, raised, and have always lived in Philadelphia. In San Francisco, most of the heroin addicts are from out of the city. In other words, they moved there. And most of them, when they first moved there, they tried the black tar heroin, not knowing that it really wasn't like the other heroin, and they actually stopped using for a while. They actually stayed sober. Many of them actually stayed sober until they established lines of supply to the more pure heroin that was cheaper. So what the authors state, which I think is kind of an interesting leap of logic, but they say that the black tar heroin was actually protective for these users because it helped them stay sober. My argument for that is what it did is it made them look harder for new sources. But, I mean, they did stay sober for a while. Many of them ended up through detox, but eventually they were able to find connections to higher purity, which replaced that. So, and as I said, the Colombian heroin is more easily replaces pharmaceutical grades. So it was also, so drug cost is another big factor. And again, here in Wisconsin, I can tell you that heroin is dirt cheap compared to prescription drugs, and it's getting cheaper because the cost of prescription drugs, when I talk to patients, is going up. To buy Oxy on the street has increased, I think, by 200%, if I remember my numbers correctly, whereas the price of heroin has stayed very stable, and it's pretty cheap, and it's been cheap for a long time. Most of our heroin is through that Colombian trade route. We don't see a lot of the black tar. I haven't heard a lot of patients talk about this, so most of ours is similar to Philadelphia. But the high purity in Philadelphia with the low expense obviously is going to switch, it's going to help people switch over. So high purity, low cost, more increased risk of progression. Low purity, high cost, obviously less. I mean, that's basic economics. The other issue is that as the supply, this is a supply-demand issue. A lot of this talk could have been given by an economist, quite honestly. Because when you start to crack down on the number of prescriptions that are being written by physicians, so you start to tell physicians, look, we're not blaming you, but that's what they say, this is what they say. We're not blaming you, but you're part of the problem. You're prescribing way too many opiates inappropriately. And the problem is, if you look at what happened in the 90s, we are, as a profession we are, but it came out of this whole pain isn't being treated adequately, people are having a lot of pain. So, but as we start revving that back, so now there's all these guidelines coming into place, there's all these recommendations. I mean, we've developed some of our own guidelines for the emergency department, for primary care, about what to do when, how to really monitor and treat people with chronic pain. As that happens, physicians are more wary about prescribing. So you're seeing the supply diminish. As the supply diminishes, the price goes up. So, and that's just common supply demand, supply and demand chain economics. So, when that happens, if the price of heroin is stable, which it has been because the supply of heroin hasn't changed, you're going to find that people are going to switch to less expensive because these are people that don't have financial means to go with the increase. I mean, patients with addiction don't usually have jobs. They don't have a means to make money so that they can then pay for higher, more expensive drugs. Because these aren't insured. This is not. It's not like they can go to their dealer and say, "Hey, I have health insurance. I want my oxy." So they're not. It's not getting paid for them. Heroin's cheaper. Do the math. I mean, most of these patients, because their addiction isn't treated, they're going to move over to heroin. And then drug availability. So again, as we've gotten better at realizing that the prescription drugs are leading down this path, and we've seen that spike in deaths and morbidity, we've started to cut back on how we've changed our prescribing patterns as physicians because we realize it's causing more harm than good. And as that's happened, we've noticed now that people are switching to heroin because unfortunately we haven't treated the addiction, which I'll talk about. But so what dealers have realized is that, okay, I can't get oxy anymore. My supply chain for oxy is running out, but my clients are coming in wanting oxy. But heroin's still available. So I'm going to get some heroin so that when they come looking for oxy, I can at least offer them the heroin. So dealers have gotten smart, and so they've changed their patterns as well. So many dealers that used to never deal in heroin have switched that too, and they carry some heroin around so that if someone comes looking for drugs, they want to be able to make a profit either way. They want to have something to sell that person. And unfortunately, that's another thing that's happening is that as we've started to decrease, the supply of heroin is actually probably increased, although it's not very well measured, because dealers have probably increased. The people that were not dealing in heroin before are more likely to be dealing in it now because they don't have prescription opiates to make money with. And then again, this is the same thing with drug geographic distribution. So if you, people think that, well, you got to go to the inner city to get heroin. You can't just find it. That used to be true. That's no longer true. Waukesha has a huge issue, and it's not inner city. And even in Waukesha County, most of the people that are selling are middle-class individuals who have gotten hooked on drugs. So, and that's true anywhere now. I mean, the majority of the patients I admit, and there was a very good reason why I chose the cases I chose. And I don't know if anyone's noticed that, and you'll notice it with the third one. They're all Caucasian. I did that on purpose because I want people to realize this is not an issue that's isolated to minorities. It's not an issue that's, in fact, when you look at the data, African Americans and Hispanics are less likely to progress to heroin than Caucasians are. And part of it is, in the past, the people that were able to afford, or the people that had been able to afford prescription drugs and that had access to health care were Caucasians, mostly. They were the middle-class individuals. So they had access to health care. They were able to get the prescription drugs. When that ran out, guess what? They're not treated. They ended up on heroin. So I chose that on purpose because there's still this stereotype that it's your minority groups that are using these drugs, and that is not true. It's everybody, and the majority of the patients I treat are not minority groups yet. Not anymore. Not that they don't have problems, by the way. I'm not also diminishing because there's still problems in that community, but we're seeing a shift in the demographics as well. The other thing that happens is, if once heroin becomes more widely available, as it spreads into these suburban areas and these enclaves, and people around you are starting to use heroin, that feeling of, oh, that stuff is deadly, that stuff, it normalizes it. So people that would normally have said, I am never using heroin, that drug will kill people, I've seen what it does to people. Once you see your friends, your peer group start to use heroin, it normalizes it for you, and you realize they're not dying, at least not initially. So it increases the chance or the likelihood that you're going to use it. So, and most people that are addicted aren't using in isolation. And opiates are especially, that's especially true with opiates. Many people congregate when they're using, and they share a lot. That's how Hep C is spreading. So, you know, the war on drugs, we spent a lot of money in this country fighting illegal drugs, not realizing that we're creating this problem in another way. So this is the last patient, 53-year-old, 53. This is a very recent patient. Caucasian female. She has a past medical history of chronic pain, secondary fibromyalgia. She presented for her first ever admission for heroin dependence. Interestingly, she was first prescribed opiates by a PM&R physician for fibromyalgia 4 years prior to admission. 1 year ago, she was prescribed fentanyl, and 1 year prior to her coming in, she still had prescriptions for fentanyl and oxycodone for pain control. About 1.5 years ago, she started to get in trouble with her pain provider because she was running out of her scripts early. But she says she never took more than prescribed. And she reports that her daughter, who was at that time living with her, whom she states is an opiate addict, was using heroin, was stealing her fentanyl and her oxys. Even she says that she was missing them, even though she tried numerous times to hide them, to lock them up, but they were still going missing. Her pain management provider eventually terminated her because she was running out early too many times, and there were concerns about what she was doing with the drugs, and she, according to pain management, they felt she was a liar because she was running out. So she was able to find other providers initially, but she still had the same problems. His daughter was still living with her, supposedly, and so she ended up losing a couple other prescribers, and then the word was out on her, apparently, or something. I don't know how word gets out because you're not supposed to talk to each other, but apparently people in the system, and I think part of it is once, even though we can't communicate, HIPAA, once you're in an electronic medical record system, you're in the EMR. So once you've been tagged at Aurora, you're tagged at Aurora. It doesn't matter, and that's kind of what happened. I mean, and once you've been tagged at Wheaton, same thing, United. So she'd gone to several different providers. When she finally ran out of prescribed opiates, she became desperate. She started having significant opiate withdrawal symptoms. They were quote unquote unbearable. And the problem is her pain really ramped up, which is not uncommon in fibromyalgia, which is why opiates are actually contraindicated for fibromyalgia, because over time they actually make the pain worse. And she had severe anxiety. Interestingly, her daughter was very kind. After stealing off her meds, her daughter decided, Mom, I really feel bad. Here's some heroin. So she started snorting heroin about a year prior to admission. And 6 months prior to admission, she had progressed to injecting drug use. Was injecting up to a gram of heroin a day. So she's tired and desperate, and she wants to be off the heroin. She's just tired of the cycle. Interestingly, prior to that use to the opiates 4 years ago, she really hadn't utilized any controlled substance. I mean, she had been on some pain meds here and there for surgeries and other stuff, but really nothing of consequence, and never really had any problems with drug use. She does not believe, and this is important. She really, when she came in, she swore up and down she would not have good pain control without opiates. She was adamant. She said, Doc, there's no way, and she was very afraid of detoxing. She had tried all traditional medications for fibromyalgia, although when I started talking to her about names, she didn't remember half of them, so she really hadn't tried all of them. She thought she had tried all of them. The only one that she had actually tried was pregabalin, which is Lyrica, for those of you who don't know. And it is a good medication for fibromyalgia, but she couldn't tell me what dose she had been on. She didn't know how long she had been taking it. I mean, you have to take the medication for at least 4 weeks. You have to get up to pretty decent doses for it to really help, but she couldn't remember. She complains of an infected injection site, and she had a huge red welt on her left dorsal of her hand. Tremors, anxiety, sweats, and she was starting to have bone pain or pain. She denied any abdominal pain, nausea, and vomiting, diarrhea. So she wasn't in severe withdrawal yet, but she was kind of revving up. She had the chronic pain syndrome. depressive disorder. She was pretty depressed, and she did smoke cigarettes, but she didn't have any other drug use history, at least that she shared with me. Medications, at some point she was prescribed cyclobenzaprine by a, I can't remember if it was a primary care or psychiatrist, but she had someone that was still prescribing some meds to her. It was actually a psychiatrist. Psychiatrist had prescribed diazepam, which had run out of a week ago, and he wasn't willing to refill it because she was using heroin. But he had given her Cymbalta, which is also good medication for fibromyalgia. So someone had actually done some good work on her. So she did get started on the Cymbalta, but she was still not an adequate dose. She's still living with her husband. Daughter, fortunately, is no longer in the home. For her, it's fortunate, because otherwise there's no way she's going to stay sober. She's unemployed. She wants to get back to work, but she's currently unemployed. She has no history of trauma or abuse, which is also fairly unusual for a lot of our patients. Husband is sober and apparently fairly supportive. His thing is, I just don't understand why we just don't stop using it. I mean, just stop using it. If it's that big of a problem, just stop it. Father has a history of heart disease. Mother had a history of depression. There was a history of alcoholism in some second-degree relatives, the uncle and grandfather. And obviously her daughter has a long-standing history of heroin addiction. She had dilated pupils. She was in some withdrawal. She had dilated pupils when she presented depressed. She was very anxious. She really felt like she was going to die, even though she actually looked pretty good. She had track marks, and then she had this big infected dorsum of her hand where she had blast injected. No cardiac murmurs, nothing else that was of interest, no history of other psychiatric issues. Her labs actually look pretty good. Unfortunately, she has not contracted any venereal diseases. So how do we prevent people from getting to this point? I mean, how can we stop the progression from prescribed opiates to heroin? Obviously, the first thing is we have to decrease the supply of prescribed opiates. Right? And by that, I don't mean that opiates should be banned. I think opiates have their place, and they're very good pain medications. They're great for acute pain. They're great for people who have cancer pain or who are dying. But there's no data, and I have all sorts of studies on this. There's no data that they're good medications for chronic non-cancer pain. So headaches, back pain, fibromyalgia, neck pain, chronic abdominal pain, chronic pelvic pain. I mean, the list goes on. There's not a lot of good data that they actually work long-term for that. They may work for exacerbation short-term, but you should never be on them long-term. So the first thing is we've got to change the prescribing, the culture of opiate prescribing. We have to start realizing that pain is not an avoidable thing. I mean, you can't just tell people you're never going to have pain. I can avoid it. I can help you so you'll never have pain. What I tell my patients, I can make you pain-free, but you ain't going to be among the living. And if a doctor, and I tell patients, if a doctor tells you they can make you pain-free, they're essentially telling you they're going to kill you. Because that's the only way you can make someone pain-free. We live in a life, I mean, in this life, we're all going to have pain, whether it's emotional or physical. It's part of life. I'm not saying that you have to suffer. What I'm saying is that there's going to be some pain involved. We can treat the pain appropriately and get you to the point where you're functional, but you can't expect to be pain-free all the time. It just doesn't happen. So we need to improve education about what are the actual benefits of being on these drugs. What do they actually work for? And what are the risks? I mean, we've talked a long time, and when I was in medical school, one of the biggest things I always heard from pain management, don't worry about opiates, give them to, if they have pain, they'll never get addicted. People with real pain do not get addicted to opiates. That is a complete myth. In fact, most of the people that get addicted have chronic pain. And they have real chronic pain. And it needs to be treated. But they also have addiction. So you need to be aware of how you treat it. So we're, you know, as a profession, we've realized that this has become a problem, and now we're switching gears, which is going to cause some issues in prescribing patterns. We're trying to become more appropriate prescribers and stewards of these medications. So, you know, the other thing I've seen in recent years, which I never saw when I was growing up, I have broken pretty much every bone you can possibly break And I was never, when I was young, prescribed an opiate. No one even offered it to my parents. I mean, my mom went to the ER like, I don't know, I think she was a frequent, I mean, at one point they called child protective services because we were there so often. One of the four of us was always in the ER. But I mean, we would go to the ER, we would always have something wrong. I mean, I broke my finger, I broke, my ankle, whatever. They would never offer an opiate to a kid. I mean, the first time I broke something was I was 8. And I mean, it's not like they would go, now you go to the ER and your 8-year-old is going to be offered Vicodin for a fracture. I mean, part of that is there's been this huge change in the understanding of what analgesia is and what constitutes good pain control. It does not require an opiate. I have since broken bones even in my adulthood, and I still not used opiates. I was offered opiates. I broke my radius about 3 years ago, and the first thing that the ER doc says, "Want some Vicodin?" I said, "No, I'll be okay." And 2 days later, the pain was manageable. I mean, it was still hurt, but I took ibuprofen, which the orthos don't like because it delays bone healing by a day, which is not a big deal, but they get all pissy about that. But by the way, the bone heals just fine. It just takes 24 hours longer. But they get all upset about that. But so we have to do a better job of using these medications appropriately. And if we do prescribe them, so that let's say you get someone that has been through everything, they've actually gone through physical therapy, which most of our patients haven't. They've gone through all these other modalities to treat their pain, but they're still in severe pain. Their functional status is crappy. They're not able to work because their pain is so bad. So they are on chronic opiates. We need to do a better job of making sure that we have safeguards so that we know when a patient is getting into trouble. What that means is drug monitoring. We need to make sure that when we have someone on a medication with a potential significant side effect, we're monitoring their progress, which means you check in on them every once in a while. You see, you do drug tests, not because you believe they're going to use, but because you want to make sure that by chance, which happens all the time, they haven't gone to some other doctor, said they were anxious and gotten Xanax on top of their opiate. Because if they get Xanax on top of their prescribed opiate, the chance that they're going to die is much higher. So the reason you do drug tests isn't just to make sure that they're taking what they say they're taking or what they're supposed to be taking. It's to make sure that they're not taking something else that someone else has prescribed, well-meaning, but the patient doesn't think it's a big deal and they didn't report it to you, and now they're in trouble because they're taking Xanax and Percocet and the chance that they're going to die is much higher. And that happens all the time, by the way. Patients don't realize that some of these medications have very strong interaction. The other one, the biggest one I see is Soma. Soma, people, I don't know, Soma is a drug that in my opinion should be banned. It's a muscle relaxer, at least that's how it's used. It's really a barbiturate. 20% of overdose deaths in this country are related to Soma in some fashion mixed with something else, usually an opiate, because it's people with chronic pain. And the majority of the people that die are people that are in pain management, either with primary care or with a pain management provider, who are prescribed Soma with an opiate. They take it exactly like they're supposed to, and guess what? They stop breathing. So they didn't overdose, they weren't abusing it, they took it like they're supposed to. So it's a big problem. We need to be better stewards of this. And then using other tools to checking. We have a great Wisconsin prescription drug monitoring program. I actually abbreviated wrong. It's WP, there should be Y. They got out. And pain management agreements. The reason we do pain management agreements, people think, I've had people say, well, that's ridiculous. You're already accusing me and I haven't even done anything. Pain management agreement is so that it's a contract between the provider and the patient, so that you understand what you should expect from me. So if you do get in trouble, I'm not just going to say, bye-bye, good luck. I have a responsibility. I have a responsibility to get you to appropriate treatment. So if you do get in trouble, and it looks like you're abusing the medication, you might be addicted, it is my responsibility to make sure you get the treatment you need. So that's part of my responsibility as a provider of pain medication. The patient has their responsibilities, and part of that is educating the patient. These are very highly controlled substances. You don't want to just leave them lying around so your teenager can get them and take them to a party, because that's the entrance fee to a lot of parties nowadays, is to bring pills. It used to be money, now it's pills. So you don't want to just leave them lying around. You want to lock them up. You want to have an understanding. These are very dangerous medications. I'm not worried about the patient. I'm worried about everything. I'm worried about the medication. The medication is dangerous, and the patient is less likely to die without that medication. So I want to make sure that patient is safe. I want to make sure they understand how important it is that they they maintain safety around that medication. So pain management agreements really spell out the responsibilities for both parties and what will happen if one or other party breaches that. Typically, it's a little bit more one-sided towards favoring the provider, but it's not. It's really supposed to be a patient care tool as well. Provide patients with education. This is huge. I think we don't do a great job in general of telling patients what the risks are of being on these opiates. What is the risk of addiction? I mean, I still had primary care docs say, and I've heard it, that, well, this patient has real pain, they're not going to get addicted. Well, that's not true. You can't tell a patient that. I know primary care in the past, when I was in residency, one of the things they told us, well, don't tell them they're going to get that addiction is a problem because they won't take it then. But that's part of informed consent. If a patient doesn't want to take a pain med because they're afraid of getting addiction, that's part of informed consent. They have to be aware that that's a risk. And it is a risk. It's a risk whether you have pain or not. Cancer patients can become addicted to opiates, okay? But the other thing is it's important that they know they got to keep them safe, especially away from children and young adults. Children, it's more accidental. Young adults are usually looking for them. Not necessarily because they're addicted, but they want to be in with their friends and all this stuff. Non-opiate options for pain management. I think it's important that providers have discussions. Pain can be treated. I treat pain all the time with non-opiate pain options, and patients do pretty well. I can't say that their numbers go down as far as what they rate their pain, but their functional status does improve. I mean, you see them on the unit. They actually are moving more. They're interacting more with peers. They're playing Xbox bowling, which they weren't doing before. So, and then educate youth. I mean, I think we need to start educating kids at a very young age. And NIDA has a really good curriculum, actually, that starts at kindergarten about the risks of illicit and prescription drug use and what its effects on the brain especially. And this is all primary prevention. So this is before someone becomes addicted at all. And then we have to do a better job. And I think Racine and Kenosha have done a much better job. I think the government in general, the federal government has figured this out. The state is doing a really good job of improving strategies to ensure that some of these drugs that are sitting in medicine cabinets are disposed of. And they can't just dispose of them in the toilet. We don't want that because that gets into drinking water. But there are collection sites. Most of them are police stations, which is no one wants to go to a police station to dump off their leftover tramadol or whatever. But right now that's what we have. It works well. Last year, I think in Wisconsin, the data was 20,000 tons of controlled substances or prescriptions were destroyed because of using collections. So if you're not using it, you should get rid of it. Do not save it for a rainy day. Okay? So if you're prescribed Vicodin, you have some leftover, do not keep it. Get rid of it. It increases the chance that someone you love is going to have a problem. Secondary prevention. So preventing progression. So now you've got someone that is on opiates. What do we do to prevent it or is addicted? So the other thing is, we need to advocate. Everyone talks about how important it is to treat addiction, but we need to actually start developing models that really are seamless so people can get up and down the levels of ASAM criteria care without having insurance gaps, without having problems getting there. I mean, right now, for example, a Title 19 patient, a Medicaid patient, we can't get them residential treatment. Whether we think they need it or not, it's just not an option. And that's not because of the state, by the way. Everyone thinks it's because of Wisconsin, but that's actually a federal government rule. No state can do it right now. It's a big rigmarole, but the state would have to get an exemption through the federal government. And it's a big hassle. I know we've talked about it at higher levels. I mean, I've talked to people about it at the government here, and they're looking at that. But I mean, we just don't have access. All patients don't have equal access to necessary care right now. So if we don't treat addiction, it's going to progress. I mean, people are going to switch. If we don't treat them, if oxycodone all of a sudden disappeared, if Vicodin disappeared, those patients are still addicted. They're going to move to other drugs that are available, whether it's tramadol, whether it's whatever, the codeine, whether it's heroin. They're going to find it. They're going to move there because they're not treated. So we need to make sure people get into the right level of care. Now, not everybody needs to come inpatient and detox. Some people can go into intensive outpatient partial hospital. There's a lot of different levels of care. We just need to put them into the right one. And ASAM has a great, I think it's a great building block. They actually have ASAM criteria, which really delineates, it's an evidence-based, or as evidence-based as it can be, it's evidence-informed, guidelines on where patients should be in their treatment depending on the severity of their illness, and it's codified on several dimensions. And it works really well if it's used appropriately and if you can actually get people into the right level of care. So, I mean, one of the things is on a funding level, we need to advocate that third-party payers and government, insurances, that they provide adequate payment and reimbursement. I don't mean that. I mean, none of us are trying to get rich here. But patients need to know that they're not going to get billed for services and that they have access to that care. I mean, right now, our Medicaid population doesn't have access to residential treatment, and some of them need it. Right now, insured patients, this is interesting, Medicaid patients, injectable naltrexone, not a problem. $2 to $3 copay, I can't remember exactly, but it's covered by Medicaid, it's a benefit, it's not a problem. Insured patients, on the other hand, are a big problem. So if I want to use Vivitrol or injectable naltrexone on one of my opiate addicts who has insurance still through mommy and daddy, I can't, because they can't afford it most of the time. Because their insurance either doesn't cover it or they say they cover it, but the cost is the same as it would cost if they weren't insured. I had that happen. I had an insurance company tell me, yeah, we cover it. I said, okay, what's the cost? Because I need to tell the patient. Well, it's going to be $1,200. I said, but that's the cost without, well, that's what we cover. I said, but that's the cost without insurance. Well, that's what we cover. I'm like, okay. So essentially, and our pharmacy can do better even than that. So the insurance companies is a big problem, especially for parents. And Vivitrol is expensive, but it's no more expensive than if you're on chronic therapy with Suboxone on a regular basis. So, in improved availability of agonist therapy, one of the biggest limitations we have, as many of you know, is there's a limit on numbers of people that can be treated with buprenorphine. You can talk to different people. There's people that say, well, if we increase the numbers, then everyone's going to be on buprenorphine. We're going to have tons of people prescribing that all over the place, and then we're going to have everyone switching to buprenorphine. That may be true. I can tell you this about buprenorphine. People don't die because of overdose on buprenorphine. It has a ceiling effect. It's a very unique opiate. It's very hard to overdose on buprenorphine. Very hard. I mean, because the way it works is, even if you saturate all the receptors, only 70% of the time is that buprenorphine active like heroin. So 30% of the time it's just sitting on the receptor and not touching it. So the likelihood that you're going to stop breathing, even if you overdose on buprenorphine, is very, very small. The problem with buprenorphine is mixing it with other stuff. Just like any other opiate, you don't want to mix it with Xanax, alcohol, the other stuff, then it's deadly. But by itself, it's actually a lot safer than what we have out there. Continue to train physicians in training. What I mean by that is medical students, residents, about addiction. When I was in medical school, my addiction class was literally 10 minutes. When I was in residency, my addiction class was detox. Here's an alcoholic, detox them, this is what we use, get them out of the hospital. That was our addiction class. There was no aftercare. I mean, I wasn't even aware that there was treatment after detox until I finished residency. Because we never did it. When we discharged patients, they were just discharged. We didn't even do aftercare. I don't even remember follow-up. It was just followed to the primary. That was in Milwaukee. Anyone cares? Develop educational programs for high-risk patients in chronic opiate therapy. So, one thing we're doing at Wheaton right now is we're developing, and Stacy's here, she'll be proud that I'm actually mentioning this, an opiate safety program, or an opiate safety group, so that people that are high risk on chronic opiate therapy, so pain management puts them on an opiate, they're high-risk patients either because they have a history of addiction, even if they're in recovery, or because they meet other criteria, like they have mental illness, which is a high risk for addiction. We are developing an opiate education group, or an opiate safety group, so people go through an educational program with a therapist once a week so that they can learn how to maintain safety with these drugs, what to do if they're in trouble, et cetera, et cetera. Establish pain management protocols. So make sure that people are using the safeguards, and that means that if you're treating people for acute pain or postoperative pain, that you're not just giving them 3 months of refills, that you're utilizing opiates for short periods of time, for acute pain, for postoperative pain. 4 to 6 weeks is the majority of the people that's what they're going to need. Utilize pain management agreements for people on chronic opiate therapy so that they understand the risks and benefits of these drugs, which is usually described in there, so that they know what their responsibility is, what your responsibility is. Utilize Wisconsin Prescription Drug Monitoring Program. For physicians, this is huge. It actually, the whole legislation, the second round of it this year, one of the things they want to do, which a lot of physicians are against, which I am not one of those, is that every time you prescribe a controlled substance, you have to check the Wisconsin Prescription Drug Monitoring Program, because then you'll know if Joe Schmo got a prescription for Xanax before you give him the Vicodin, and you can talk to him about that. Which they may not tell you, not necessarily because they're addicts, but just because patients don't know any better. Most patients don't realize that that's a problem. And advocate for low use of lower abuse potential opiates. There are differences between the opiates. Not every opiate is as likely to cause problems. And then what do you do when someone actually progresses to heroin? Well, number one is you treat them. So this is all the same slide. But number two is, we need to, and Wisconsin is ahead of the curve with the whole legislation that Representative Negrin's put out there, as far as improving access to needle exchange programs, and especially decreasing overdose rates by increasing the availability of Narcan, naloxone. If you keep, and people argue, well, that's going to increase the risk that they're going to abuse more. And the bottom line is, if you give a patient enough time to get better, chances are they will get better at some point. If they die, they ain't getting better. They're dead. So if we can keep patients alive, and I've seen a number of patients that this has been true for, that have overdosed once, twice, 3 or 4 times, and eventually it's sunk in, and they've really bought into the program, and they've done well, and they're productive members of society. Not everyone gets there, and I tell people, addiction is a terminal illness. It's no different than cancer. If I diagnose you with cancer and you tell me I don't want treatment, chances are you're going to die. Addiction is no different. If I diagnose you with an addiction and you say, okay, I don't want treatment, I'm happy, the chances are you're going to eventually die and succumb to the addiction. So addiction is a terminal illness without treatment. It's no different than cancer. It's no different than diabetes or high blood pressure. It requires treatment. And then identification and treatment of substance use complications. I mean, like my 53-year-old woman that had a skin infection, got to treat those and prevent them. And then try to prevent progression to these issues. So with that, I'll open it up to questions. Yeah?
Methadone was rather conspicuous by its absence. Is that treatment considered old school this week?
No, I consider that as part of agonist. I put agonist therapy. It's not old school. It works just great. I mean, you have to have a good methadone program. The hardest part nowadays is most of my patients don't want to be on methadone. Methadone is like this. Amazingly enough, methadone is a bad drug. People die on methadone. Like, you're injecting a gram of heroin every day, and you're worried about methadone, which is going to be actually prescribed to you on a, So there's a lot of misconception and myths about methadone. It works. You have to have a good treatment program. They have to be appropriate dosages. I mean, I've seen people have ridiculously high doses of methadone that are non-evidence-based. But if it's used correctly, it works just as well as anything else. Especially, I mean, it has the most data. It has more data than buprenorphine than Suboxone. But to me, Suboxone and methadone are equivalent. The only difference is the stigma associated with methadone, that you have to go to the clinic every day, and people know, they're going to see me outside QAM. Which you don't wait outside QAM, for example. I mean, they actually have an inside. I mean, it's not like there's a line that forms outside QAM. But people have that misconception. I mean, and it's real to them. I mean, so it's a big, it's a big problem. It's a hurdle to overcome. And the other thing I didn't mention a lot is antagonist therapy, the Vivitrol. I mean, I said that it's not paid for, but that works very well. There's growing literature that it's a very good first-line agent for opiate addiction. If you give someone a blocker, and that's what Vivitrol is, it's a pure blocker, they can't get high, at least not the first couple of weeks. Now, the big bad thing about Vivitrol is that two things happen. One, you reverse the addiction immediately. In other words, a dependence. So that if they do use and they use the same amount, so if you get someone using a gram a day and they go back to a gram a day in about 3 or 4 weeks at the end of the injection, they're likely to overdose because their tolerance is gone and they don't realize that. So there have been reported overdoses in people on Vivitrol who have tried to overcome the blockade, usually in the 3rd or 4th week, because the 1st and 2nd week the blockade is pretty strong, but in the 3rd or 4th week. If you get the Vivitrol on a regular basis, so you don't use, you're getting it regularly for the first 3, 4, 5 months, the chances of overdose are much less because you get a much more stable blood level. So you're more regularly blockaded. But it's a very good medication. And what I found when I've used it is, and I don't have a good explanation for this, and I don't think our medical community does either at this point, is theoretically or conceptually, I would assume that if I block their opiates, these people are going to get severe cravings. Because all of a sudden they don't have opiates, and now you're blocking the receptor, so they must want more opiates. Well, amazingly enough, after about 2 weeks, their cravings are pretty much gone, as long as they stay on Vivitrol. And I can't explain it, except to say that there's something about just the molecule sitting on the receptor and blocking it, just sitting there, that makes them not want to crave it. I don't know how to explain it, because conceptually, in my mind, that was the big thing I had about this is if I give them a blocker and they're already craving because they're missing that there's no opiate sitting on the receptor. Now I'm blocking the receptor, so no opiate can sit, not even the endogenous ones. So their endorphins can't even sit on that receptor. I would expect that they're going to crave more. But the data is pretty clear. My patients that have been able to convince to use it have all told me it's pretty consistent, 10 to 14 days, their cravings are just gone. They just don't think about it. The first 2 weeks are pretty much hell on Vivitrol. I mean, they have a lot of cravings. But after that, they don't think about it as much, or at all, and it's really amazing. I don't know how that works, but it doesn't work at all without therapy, and that's, and I'm speaking to a room full of probably mostly therapists, so I'm sure you guys know that already. I mean, medications, if you look at the data on just using a medication, whether it's Suboxone, Methadone, Vivitrol, they're not that effective by themselves. I mean, the relapse rates are extremely high, 85 to 90% relapse rates just with, it's less than if they did nothing, but it's still very high. They're very high relapse rates. It's combination of treatment that really works the best. And when you talk to people that have been in recovery, it's only until they really bought into everything that they really recovered. I have people that come in, they want Suboxone, and I kind of know, that's all they really want. And, fortunately, the Suboxone prescribers that I have require them to be doing something else, but they, unless they really buy into it, it's harder for them to stay recovered.
Any other questions?
Yeah.
Not necessarily totally related, but I guess I have and I think a lot of the students have a big concern that kids in this area are just heavily warehoused on a lot of psychotropic medications. And sitting on a child duty for 15 years, you see the progression of where it leads them. I was going to speak to that.
It's a very broad topic. I'm not a psychiatrist, so I'll start with that, okay? And so I can't speak to whether it's appropriate or not. I haven't looked at that data as far as, whether kids being on all these medications, whether they're psychotropic. Mostly, I'm assuming you're primarily talking about psychotropics. I can't tell you whether they're appropriately medicated or not. I personally have seen an increase in the use of psychotropics in kids. But I can't speak to whether it's appropriate or not. Do I think it causes problems long term? Anything, in my opinion, and the data is not out yet on this, but anything that affects the brain, anything that affects the neurochemistry is going to affect brain development. It has to. If you change the soup, it's going to change the taste. It's going to change the outcome. You're changing what the chemical composition is of the brain, which is why we know that things like nicotine, marijuana, alcohol cause delays in neurodevelopment, and they actually cause neurocognitive problems when it's used differentially when it's used by someone adolescent versus someone adult. So what I'm saying by that is, so if you take a 13-year-old who's using marijuana and uses continuously, and you take a 26-year-old who started using marijuana at 26, first of all, the rates of addiction are different. The chance that the 13-year-old is going to get addicted to marijuana is about 15% of that population gets addicted. Use after age 25, about 9%. So the rate of addiction is lower. Neurocognitive development is different. So the chance that this person who's 13 is going to have a successful life and have, and you can measure success in a number of different ways, but be able to have a meaningful or productive life, or whatever they measure, is very low compared to a 26-year-old who maybe, at that point has finished college, presumably, or has been working, and is in the process of going to their career. And their brain has already developed. So the chances that they're going to have long-term neurocognitive side effects from marijuana use are much lower, even if they use daily, than someone who starts using at age 13, when their brain is still developing. So I can't answer that question because I don't know that anyone's looked at prescribed psychotropics. I can tell you from the standpoint of stuff that's not prescribed or things that people abuse, it causes significant problems with neurodevelopment. Yeah.
Give a reference to the drug education program for schools.
It's the NIDA. There's several, but the one that I looked at is the one from the National Institute of Drug, or NIDA. I think it's the National Institute of Drug Abuse, I guess. And they have it's on their website. It's an entire curriculum. There's other ones. I know Racine uses one. I don't know. I think Notion has something. I don't know, maybe not. But I know Racine has something that they use as well. But there's a number of different curricula out there for starting to educate kids about the effects. And it's not like you're going to say, okay, don't use cocaine at age 2 when you're 5 years old. It's more of, when you put stuff into your body, it has an effect on your body, and they go through different things, and it's more like that. And then they talk about the brain. I mean, it's a very progressive curriculum over the first, I think it's the first 5 years of school for NIDA. So it's from kindergarten through 5th grade, I think, or kindergarten through 4th grade. And it's a pretty, I think it's very, now, we don't know for sure what, I guess the other thing is, as far as evidence, I can't tell you that there's been studies that show that decreases use. I don't know for sure. But I guess my thing is, what's the harm? The dealer is approaching these kids at a young age. They're not going to wait for these kids are in 8th grade. They're going to start young. So why shouldn't we approach them first and just get them to understand what happens when they put stuff in the body?
That article, I was at the bottom, I was reading every member I that came through. Where do I get that?
Actually, you can get it. It's free. It's one of the, because it's a NIDA sponsor. You can get it if you look at. The best way is to go to PubMed, PUBMED.com. I think it's .com or .org. But and that's a repository. Basically, if you do a search in there, I'm trying to get back to that. If you do a search in there, so it's this article. If you do a search in there and put either the name of this investigator, or you put transitions from opiate pills to heroin, you just write that in there. I think this is the first article that comes up. And then you can go through the links, and it'll allow you to download the PDF. So it's free. So I mean, it's available because it was funded by NIDA. So anything that's funded by the federal government is usually available for free. Okay. Yeah.
How you doing?
Hi.
David Bird. I'm a senior here at Parkside, and like doctors and police officers, not all police officers are bad, right? We have good cops, we have bad cops. We have good doctors, we have bad doctors. You agree?
Yeah.
Now, from my personal experience, I think they give you something and they don't tell you what it is. But maybe some doctors do explain what it is. Well, I was in a hospital about 15 years ago. They said, here, take this pill, and you'll sleep like a baby. I said, okay, yeah, I want to sleep good. High as a kite, that cliche, good night. I was so high. The next day I woke up, I had these crazy dreams. I said, Doc, come here. I said, what you give me? See, he didn't even tell me what he gave me. But I figure I'm the patient, he's the doctor, so I don't know, I'm gonna listen to him. He says, Vicodin. I said, I don't want to take Vicodin. He said, this is exactly what he said. You gotta take it. Now I remember my mom telling me I gotta go to school. I gotta do my homework. I gotta do my chores. That don't kind of agree with me when he said you gotta take it. You understand what I'm saying? So I didn't gotta take nothing. I said, well, you have extra strength Tylenol?
Yeah.
And then I gotta take that.
Yeah.
You see the difference?
Yeah, and that's what I was telling. I mean, as far as education, that's what when I talk about informed consent is when we tell patients, when a patient comes to us, the assumption is there's a power differential in that relationship, right? It assumes, now, not always, sometimes it's wrong, but it assumes that I know more than the patient coming to me, right? So the assumption is that, and you know what doctor actually means? Doctor comes from the Latin term docere. It means teacher. The primary job of a doctor is to teach. So when the patient comes to me, my job is to educate them on what the options are, because I know what the options are. The assumption is they don't. Now, that's not always true. I have patients that actually know quite a bit more than I do. Quite a bit more than I do. And then I learn from them. But the assumption is that I know more about what the appropriate treatment is going to be and why I'm recommending that treatment. Now, do I sometimes lead patients into the right direction? Yeah, I do, because I really want them to do the right thing. But I offer them all the options. So when I talk, for example, to an opiate addict, I don't just say, okay, I want you to get Suboxone, I think that's the right option. I say, okay, here are the options. No medication and therapy, because you don't have to be on a medication to stay sober. Everyone thinks you do. You don't have to. There's agonist therapy, which is Suboxone and methadone, and there's antagonist therapy, which is Vivitrol. Those are the options we currently have to help people stay sober that I can deal. I mean, I'm not a therapist, so that as far as medication, that's what I talk to them about. And I talk to them about risks, benefits, and why each option might be better or not. In this case, I personally like to try to, especially people that have never been on anything, I like to use the least addictive, which is the injection. So I try to get them to buy into the injectable naltrexone. I can tell you that doesn't happen very often, but that's what I try to prefer. So, but I explain everything to them, because that's my job. Now, if the patient says, screw you, I don't want any of that, that's fine. Now, if the patient says, screw you, I want my Oxy, they're not going to get that. But, I mean, because I still have the option of not prescribing. They have the option of requesting or demanding. But, so it's a two-way street. It is a relationship. But my job is to educate and to say why I am or am not doing something. So in that case, and I can tell you 15 years ago, and it's changed. I'm not saying it was great then either. I mean, it is great now either. But when doctors were initially trained, and even when I was in medical school in the 90s, so about 15 years ago. Actually, no, yeah, I guess. No, it's been 20 years, I guess. I want to make myself younger than I am. But, you know, we were taught the paternalistic model. Basically, I'm your daddy. I tell you what to do, you do it, because I know better. That's what the paternalistic model was. In recent years, we've really tried to move away from that. Are there doctors still practicing that model? Absolutely. There are still doctors that are going to tell you exactly what to do, and if you don't do it, they get really pissy about it because they're right and you're wrong. But most doctors, not all, most doctors are going to try to talk to you about what the options are and explain them to you so that you can make an informed decision. That's what we call informed consent. You're consenting to treatment based on knowing what you're supposed to be doing, or knowing what the options are. So you're not supposed to be doing, but you knowing what the options are for treatment. I mean, for example, dialysis is a perfect example of that. If I get a person with end-stage kidney disease, I have to explain to them what dialysis is. And I have to explain to them what the risks, benefits, and side effects are, and what the risks, benefits, and side effects are of not doing it. If you don't do dialysis and you need it, you're dead. Bottom line. If you do it, there's a lot of stuff that goes with that. And some people don't want to go with that. So they choose not to do dialysis, and they do die. But that's a choice they make. I can't force them not to make that choice.
But
I can't force anyone to take it.
painkiller though. So I mean, Tylenol is good for me.
Yeah.
See, but I felt that he like should have schooled me.
He should have, and, right.
Yeah. Because
Well, I agree. I think doctors need to tell patients what they're giving. I mean, you can't just prescribe something and say, okay, take this, good night, you're gonna sleep good. I mean, my first experience with an opiate was not, I didn't feel high. I had an out-of-body experience. It was horrible.
that's what I had. I was young when I swear it was like.
So, I mean, I haven't had to take one again, thank God, but I mean, there may come a time. So, I mean, the bottom line is, you know, I agree with you. I think doctors need to do a better job of prescribing all treatment. And we assume that meds are benign, you know, as physicians. One of the things, we're very good about procedures. So if you're gonna have surgery, I can tell you, you're gonna get a sheet that has like 15 pages, and it lists every single potential side effect. Now, are they gonna actually talk to you about everything? No. But they're gonna expect that you read it, which, I'll be honest with you, a patient who needs surgery is not gonna sit there and read all that. But then later, when something happens, well, it's on page 53, yeah, that could have happened. So, I mean, but we're not as good with medications because we just assume people are gonna, I don't know. I don't know what we assume, but a lot of times I just think that we think people know stuff that they don't, so, yeah.
I know that I recommend some of the NSAIDs as an alternative,
Mhm.
because when you are looking at pain or Tylenol like that. But I also know that these ibuprofen has gotten, I think, all of them bad rap in the media. Is that something to believe, or at least those?
No, I mean, okay, anything you put in your body has a side effect, even water. I mean, it has a potential harmful effect. NSAIDs are not 100% safe, even though they're over the counter. So ibuprofen, naproxen, all of those, they're not 100% safe. They can cause kidney failure. They can cause all sorts of others. I have to blank right now. Stomach issues. I mean, there's all sorts of stuff they can cause. But in general, if you take all people on NSAIDs, and you take all people on opiates, the people on NSAIDs do better as a whole than the people on opiates. So when you look at a population of patients, in general, people are going to do better. Are NSAIDs for everybody? No, they're not. There are people that are allergic to them. There are people that have ulcers that can't take them. There are people that have kidney failure that you can't give them to. So in general, though, there are safer medications than the opiates for a number of different reasons. And I mean, I could put them side by side and go over that with you, but I mean, it's just the opiates have a lot more side effects. Anyway, the opiates can cause kidney failure. People don't realize that heroin can cause kidney failure, it can cause rapid, it can cause all sorts of other issues. So the other bad rap, and I know what you're referring to, is the risk of heart attacks. Interestingly enough, opiates have an extremely high link to heart attacks. That data is going to be coming out. People that are on tonic opiate therapy have a higher chance of having a heart attack than people that aren't. So it's not just NSAIDs. And the risk with NSAIDs is minuscule. I mean, the absolute risk increase is like about 1% over 10 years. We're not talking about like you're gonna have there's a 50% chance you're gonna have a heart attack in 10 years if you take it. It's a teeny tiny. Now the relative risk, which is what people calculate, is it's like a 30%, which sounds a lot, but it's not a lot in the absolute terms. So I mean, the data can get skewed all sorts of ways. So you know, and believe it or not, remember the number one NSAID out there is aspirin. And guess what we use aspirin for? Prevention of heart disease, okay? So if I have a patient that's worried about that, I give them aspirin. Aspirin's a good painkiller. It's an NSAID. It also prevents heart attacks. So, I mean, so they're not all the same either. So. Anybody else? Anyone else have a question? Yeah.
certain patients more susceptible to addiction than others, like biologically or
Yes.
genetically? And is there a way to screen that before you prescribe them opioids or whatever?
Yeah, so the question is, are certain patients biologically more susceptible to addiction than others, and is there a way to screen for that prior to prescribing drugs? The answer to both questions is yes. We don't completely understand what predisposition means, and are there different, like, levels? So, I mean, all of us have some predisposition to addiction. I mean, if I give you an opiate long enough, I can, it was some guy, I can't remember, it was an article, some guy was joking around and said, I can create an addict. You can't. I mean, I can't. If I give people opiates long enough, I can make them addicted. I can get them to really want it, and I can change the chemistry of their brain. Everyone's different on how long that will take, okay? And it depends on the opiate. I mean, if you take like codeine, it might be a lot. I mean, you may not ever be able to create an addict with codeine because it's a very low potency and it doesn't get into the brain as well as opposed to heroin. Heroin is kind of the quintessential addiction. I mean, it's just a perfect molecule to get people hooked because it just gets into the brain. It's fast on, very rapid release of dopamine, and fast off. It's a perfect drug for it. I mean, it's just if you had to design a drug to create addiction, heroin would be it. Xanax, by the way, is the second closest to it. Because it's the same, it gets in the brain fast and it comes off quickly. So there's some drug characteristics. I don't want to say it's all. So there is a biological predisposition. Now, how do we screen for that? Family history. Does your father use? Does your mother use? Has your father had a problem with addiction or alcohol? Has your mother had a problem with addiction? Do you have siblings that have problems with drug or alcohol? Do you have uncles, cousins, nephews? I mean, you can go way down the line. I mean, we look at first-degree relatives most closely because obviously you inherit your genes from your mom and dad. So most likely, if your mom and dad or both are addicted, you're going to have a higher chance. Yeah.
Is that always done before prescribing medication?
By pain management nowadays, by pain management providers, by primary care, no, they don't screen as well. And that's what we're trying to, and the majority of the people prescribing opiates isn't pain management. I mean, pain management is a very limited practice. I mean, there's very few people that do pain management compared to primary care. So the majority of people that are getting prescribed pain meds are going to come from primary care world. And they don't screen that often for risk factors. And family history is one risk factor. Other risk factors are mental illness. It turns out that if you have mental illness, depression, bipolar disorder, schizophrenia, you're at higher risk for developing addiction. Whether that's intrinsic to the fact that it's already affecting your brain in some way or not, it's unclear, but you're at higher risk. The drug characteristics, like I said, I mean, Suboxone, for example, is a lower risk drug than heroin, much lower risk drug. Suboxone is a lower risk drug than oxycodone. It's not a drug that tends to get people hooked because of the characteristics of the medication. So there's a lot of things that you have to take into account when you do a history. The other one is, it's personal history. I mean, you get people that get prescribed meds who just got discharged for detox. I have patients I discharged from detox, and 1 week later they have a prescription for Vicodin. No, they're not screened well in all settings, and they're not screened well in the emergency room. An emergency room doc is not going to do a screen for addiction before they prescribe, which is why, in my opinion, they shouldn't be prescribing opiates in the ER unless it's for acute traumatic pain. They shouldn't be prescribing for chronic pain, because chronic pain, by definition, is chronic and should not be treated in the ER. ER is an acute care setting. So, and we're trying to change that in our group, but it's a culture change. People don't know how to really do that. They don't want to say no to people. Doctors have a hard time saying, we are people pleasers, by the way. That may not seem that way sometimes when you come to us, but we really want to make you happy, because that's what we do. So saying no is very hard for most doctors. I'm not one of those, as people will tell you. I like saying no. I think it's a great word. It's generous. It's so awesome. But it's hard for many doctors to say no. I have doctors in our practice, that's the main reason they prescribe is they feel bad and they don't want to say no. It's not the right reason they prescribe it. But yes, family history is huge. That's how we trace it. There aren't any G markers. It's not like I can draw someone's blood and know that they have a risk for addiction. It's all family history, and that's how most of our history, and that's how we know most people are predisposed to things. And it's the same thing with diabetes or high blood pressure. Okay, thank you.